Hello everyone, today I will tell you about machine perfusion in transplantation. An overview of my presentation is first the OPTC function, then I will tell you about donor procedure and the donor landscape, and finally about machine perfusion in transplantation. So first, what is an OPTC? It's an organ perfusionist and transplant coordinator, and it's a very special function we have in the Netherlands of a group of transplant professionals which will take care of organs on the machine and transplantation coordinator day and night. This is very unique within the world and within Europe as well. We have organ perfusionists or OPTC's in the LUMC in Leiden, the UMCG in Utrecht, in Groningen, the UMCU in Utrecht and Erasmus MC. And we are responsible for the transplant coordination in our hospitals. So we are a part of Eurotransplant, which is 8 countries that are working together. And we get an organ offer for a recipient. We discuss this offer with the specialist of that organ. And if we accept this organ, we also arrange for logistics as well. Besides this part of our job, we are also organ perfusionists. And most of my presentation will be about this part of our job. In Erasmus MC Transplant Institute, we transplant 4 organs, the heart and the lungs of the thoracic organs, and the liver and kidneys from the abdominal organs. And we also do perfusions of all of these organs. So we do heart perfusions. In Erasmus MC, this is currently done by the clinical perfusionist. We do the lung and liver perfusion as OPTC, and the normothermic kidney perfusion, so warm perfusion. We have a student team doing the hypothermic perfusion. I will talk about more detail about these kinds of perfusion. But first of all, I want to tell you about postmortal donation, so donation after death. In the Netherlands, we have 2 types of these kind of postmortal donation, which is donation after brain death, which we call DBD. And death is determined in these patients when brain death is determined. And after that, organ allocation and organ procurement is going to be arranged. And the donor is brought to the OR with an intact circulation with oxygen delivery to the organs. So upon retrieval, these organs still receive oxygen and blood is flowing through these organs. We have also a different kind of donation, which is called DCD, is donation after circulatory death. And in the Netherlands in 2024, this was almost 65%. And you can see already in this graph that there are way more arrows and terms associated with this kind of donation. And what's most important, the difference here than with the DBD procedure, is that with switching off therapies, the donor will start to decease. And until the donor stops breathing, there is intact circulation with oxygen delivery. But if the donor stops breathing and the heart stops beating enough blood to all the organs, we have no circulation or lower circulation and no oxygen delivery to the organs, which is detrimental for the quality of these organs. And this is one of the main reasons machine perfusion is very important, to also use these organs for transplantation. I want to tell you a little bit about our donor pool and the current challenges we have. So the average donor is becoming older, and becoming older also leads to more comorbidities. Donors are getting heavier, we see more obesity. We see more the donation after circulatory death, which is associated with higher risk due to the lack of oxygen flowing to those organs. And we have waitlist mortality due to the shortage of organs. So we still do not have enough organs to help everyone on the waiting list. So why then machine perfusion? First of all, most importantly, we can do more transplantations. So organs that were upfront declined for transplantation and deemed not good enough for transplantation, we can now test them before we transplant them. So we have extra organs we can transplant. We also see that we have less injury and less complications after transplantation if we use machine perfusion. So for example, in liver transplantation, we see less biocomplications and we can prevent additional costs due to extra complications that occur. And we can also prevent retransplantations. We have some logistical advantages. We can postpone the complex transplantations for a team that's more suitable to do the transplantation. We can allow for daytime surgery, and we can allow for combined organ transplantations. The logistical advantages are mainly, of course, for all our personnel. We as OPTC still need to be there in the night to watch the organ. So it brings a lot of logistical advantages for patients and OR staff, but we still, of course, need to be there. And for the future, which is not here yet, but I hope we'll get there at one point, is the treatment and repair of organs. Like I said, we still do not have enough organs, even with this kind of machine perfusions. So we need to do something with organs that we still cannot transplant. These are the logistics of an organ procedure, donation procedure in the Netherlands. So the donor can be in the whole of the Netherlands or even within Eurotransplant. And the organ is retrieved and stored on static cold storage, which is on ice in a cool box. Then it's transported to the transplant hospital, in our case the Erasmus MC, and then the liver or other organ is subsequently transplanted. But what you can do is also already on transportation, put a kidney on a machine. So you can put a kidney on machine perfusion during transport, so not in a box with ice, but you put it on a machine. Same as for the heart, so you can transport the heart on the machine. What you can also do is let the organ come to your center, your transplantation center, on ice, but then apply machine perfusion in your own hospital. And we mainly do that for kidney, livers and lungs. And this is all something we call the ex situ machine perfusion, so outside the body of the donor. Because on the other hand, we can also do perfusion of the abdomen in the donor hospital. So instead of putting the organ on ice and transporting it, we can already do perfusion before we transport. And in that case, you have all the abdominal organs in your circuit, which is kidney, liver and the pancreas. This is called in situ machine perfusion. So the question is, what do you need if you want to perform machine perfusion? And every system is different, but all are based on the same principles. Because you need a heart to pump around the blood. So instead of a heart, we use a pump. We need lungs to provide oxygen to the organ. So instead of real lungs, we use an artificial lung called an oxygenator. And last, we also need something to transport the perfusion solution and the oxygen and nutrients to the organ. So instead of blood vessels, we have tubing. So every system for every organ is based on these simple principles you need to perform machine perfusion. I wanted to talk to you about the different organs and the current use in clinical practice. So first I would like to start with kidney perfusion. Every kidney in the Netherlands is transported on cold machine perfusion, which you can see at the top slide. So we preserve the kidneys on the cold machine, and that way we have better storage and better results after transplantation. We can also perform warm kidney perfusion, so with blood and based on body temperature. This is mainly now done for preservation, and the field is still developing in working, finding viability assessment and possibilities to assess the quality of the organ on the pump. Next is liver perfusion. This is my field of expertise. And in liver perfusion, we have also two kinds of protocols. The cold perfusion, which is to preserve the liver, but also recharge the battery of the liver. By doing this, we decrease the chances of biliary complications in the recipient. And we can also do warm perfusion at body temperature. And we have some biomarkers and viability criteria to assess if the liver is good enough for transplantation. In liver perfusion, we can also combine cold with warm to have both the advantages of the techniques. For lung perfusion, we can also do cold and warm perfusion. Cold perfusion mainly for preservation, as the lungs and other organs in the cold are not metabolically active. But if you warm up the lungs, you can also do the viability assessment with predetermined criteria. You also inflate the lungs, so the lungs will be breathing again, and you will look at the values, what the lung does with the oxygen. For heart perfusion, we are starting in the Netherlands also with cold perfusion, mainly for preservation, but we can also do warm perfusion with limited viability assessment. And if you put the heart back on the machine and provide it with blood, it will also start beating again. So you have limited assessment of the function of the heart. All these perfusion techniques are the techniques we can do ex situ, so outside the body of the donor. But I also told you about one last technique which we can do, is abdominal perfusion. So in this perfusion, instead of letting the organ come to you, we travel to the donor hospital, which can be in the whole of the Netherlands, and we perform the perfusion in the donor. So we make sure that the perfusion is only happening in the abdomen, so not at the lungs and the heart. And then we perform warm perfusion to recharge the battery of the organs, but also to assess the viability of the liver. It's also possible to do it with the heart and lungs in the system, but this is not performed in the Netherlands. This is a concluding slide about the types of machine perfusion and the goal we have in the Netherlands. So you see here that the reduction of damage during the preservation period, so when you transport the organ, we use that for kidney and heart. We already put them on the pump while traveling. If we want to improve the preservation prior to transplantation, that's what we do with cold perfusion, with the liver. And with the lungs, we're still looking at if it really improves after preservation. And functional assessment prior to transplantation is possible mainly for the liver. We are very far along in the field, but also for lungs we have established protocols, and heart and kidney we are working on as well. So if this is what we're doing already in clinical practice, what do we need to do in the future, or what do we want to achieve? So the future of transplantation, our ultimate goal will be to have more organs available for transplantation, so that we have nobody dying on our waiting list, nobody not receiving an organ in time. So how we're going to achieve that is by improving, repairing and building organs. So we need to utilize all organs that are offered to us, even the organs that are deemed not good enough for transplantation, but then we can improve and repair them. So we can treat them with defatting cocktails. So the people with higher BMIs have also a fatty liver. What if we can defat that liver and transplant that liver? Or we can give anti-inflammatory medication. And we can even start thinking about cell therapies, so providing the organ with stem cells, maybe even stem cells derived from the recipient. We can add organoids or even do gene editing. And what we're currently doing now is short-term perfusion, so less than 24 hours. And for these therapies, we need long-term perfusion to perfuse the organ for multiple days and treat it. So maybe the future will be that we have an organ hub, so kind of an intensive care for organs, where we can take organs that are not good enough for transplantation, treat them, improve them, and then send them to the recipient who needs it the most. I want to thank you for your attention, and if you have any questions, you can reach out to the Transplant Institute.